Thank you, Dr. Fishman. So I'm working with Dr. Fishman, learned a lot about essential tremors and movement disorders in general, and we've been working on this for some time. So just regarding financial interest, we have no financial interest or relationship disclosed with respect to the subject matter presented here, but we have had funding, continue to have funding from MRgFUS Foundation and SciTech. So I don't want to belabor this point. I think the previous speakers have spoken a lot about essential tremor, but the thing about essential tremor is, I guess, we treated the deep brain stimulation, and now we are very interested in using focused ultrasound thalamotomy because it's less invasive, effective, and now it's FDA approved. So again, we use data both from the continued access and the pivotal study that was done recently, multi-center study that was done. There are several resting state fMRI studies that have showed disruption of functional connectivity in the cerebello-thalamocortical circuit that can contribute to tremor in ET patients. So in general, what they've shown is that increased functional connectivity is increased in the motor cortex and decreased in the cerebellum. But there are very few studies, even with DBS studies, very few studies have looked at how the brain reorganizes itself after treatment. So here we investigated the association between the tremor improvement and the changes in functional connectivity between the ablated VIM and the rest of the brain in ET patients at 1 year after the procedure. Again, this is for people doing thalamotomy, and especially in essential, this is very normal. Typically, the VIM is targeted, and then several studies, including studies we just heard about, have shown that the improvement lasts at least up to 2 years following the treatment in terms of tremor symptoms. So in order to study the changes in functional connectivity, we had 19 patients on whom we had most of the data. 15 were treated on left side, 4 patients. On 4 patients, we had either they were treated on the right side or they were incomplete scans. So in this particular study, we only used 15 patients, all treated on the left side. We have baseline imaging studies and the CRST data is also available all the way up to 12 months and even later. So from the MRI perspective, we use 3 time points: baseline, less than 24 hours, and 12 months. And we typically use just the T1MP range and the resting state fMRI images for this particular study. These are the characteristics of the patients, the 15 patients that I was talking about. So the mean age is about 72 years. Number of sonications, 18, mean that is. We reached temperatures as high as 60 degrees, and basically the lesion volume is about 115 plus or minus quite a big standard deviation there. So that's the characteristics of our patients that is studied in here. When we do the CRST analysis, what we found out in these patients is most of the time is the hand tremor that is the most dominant. And if you look at all these 15 patients, you can see how the tremor improvement remains steady over the 12-month period. And so we chose to focus on the upper extremity tremor score. There was only a slight increased tremor in the non-dominant upper extremity, so we only chose to use only the dominant side. Given these non-significant findings, we focused our connectivity analysis to the dominant hand using scores obtained from upper extremity at rest, posture, and action intentions, and plus the hand tremor score from Part B. We also normalized the score. If you look at the graph on the right side, what you see is that the tremor severity remains subdued for the dominant side, whereas the non-dominant side there's a slight increase, which was non-significant, but there is a slight increase, and we normalize this tremor score in order to do the connectivity analysis. We also corrected for age in terms of Oh, sorry, yeah. And FDR corrected for multiple comparisons. And we used the lesion volume from the 24-hour scan in order to determine where the seed should be placed in the VIM, and did the connectivity analysis. What we find is we find a significant positive association, and we find increased functional changes in the motor function, particularly in the cerebellum and insular cortex. And typically these are related to mostly the motor function and the visual processing areas. And we also found some negative correlations, and these decreased functional changes were associated with motor control and visual motor function, and they may have modulatory effects on executive and cognitive function. The correlations are quite stunning, and of course this is a very limited set of data from 15 patients. We need to be looking at more data as it comes, and we only looked at the connectivity from the VIM to the rest of the motor, rest of the brain, but there are several networks that we still need to look into. So in summary, significant association was observed with the tremor improvement and increased LVIM, left VIM-related functional connectivity in the cerebellum and hippocampus. Decreased LVIM-related functional connectivity in the superior parietal cortex, occipital cortex, again, all the visual regions and the somatosensory regions. Major effect of the treatment appears to be on the motor, visual, and visual spatial brain networks, which makes some sense. Thank you, and the person. Thank you.
Thanks very much. Questions?
No, it was great work. Congratulations for this work. A couple of things I'd like to mention is the goal for this kind of analysis is to understand how we are changing the networks and what the mechanism is. But I think the goal is also to take this intraoperatively. And when we think about taking this intraoperatively to guide us as to how much ablation needs to be done and are we done and the treatment endpoint being achieved, I think it'll be important to study connectivity measures irrespective of VIM, because we are making a lesion there. It'll be very difficult to really study live fMRI changes at the site of lesion.
Right.
So looking at rest of the brain probably would have some value as well going forward in terms of developing intraoperative feedback methods.
Right. You're right. We're doing both structural and functional connectivity analysis just precisely to do that in order to guide treatments in the future, yes.
One question. If I understood correctly, you are using seed-based connectivity, putting the seed in the lesion.
At the lesion location at 1 year, yes. And
so my question is, what does it mean, a functional connectivity between a lesioned area and the rest of the brain? What is that telling us?
There is obviously some reorganization going on. The fact that we see in the same cerebellothalamic networks that we have connectivity still, there is some reorganization going on. It's a good question. We haven't compared with the other side as to see how different these networks are. But what it tells us is there is some reorganization. There is some reorganization of the networks as the lesion evolves, and there is no lesion. I mean, there is no visible lesion in 90% of the cases at 1 year. So.
Okay. Thank you.
Thanks very much.
Thank you.
Okay.